Hope everybody's enjoying the meeting. I'm Stuart Sweet. On behalf of the American Society of Transplantation, I'd like to welcome you to the Breakfast Symposium entitled Treatment of Adults with Hepatorenal Syndrome, Additional Data in Liver Transplant Patients. It's sponsored by Mallinckrodt. And on behalf of the AST, I'd like to thank Mallinckrodt for their continued support of the CEoT meeting. So please welcome the symposium speaker for today, Dr. Philippe Zamore from Wake Forest University School of Medicine. Welcome to the stage. Thank you, Dr. Zamore.
Good morning. I know the best way to get healthcare folks out in the morning is with a good meal, so I hope you guys are all, and of course, good education and good discussions as well. So good morning, I'm Philippe Zamore. I'm a hepatologist from Charlotte, North Carolina. It's good to be here with you all, talking about a relatively brand new drug on the market. I'm here on behalf of Mallinckrodt, and thank you again for your support, and thanks to the AST rather. So just want to dive right in to our data. So terlipressin, or Terlivaz as the brand name, was just approved, I can't recall what month, but just maybe September, August last year of 2022. Rather monumental moment for us in hepatology. Of course, it's been around in Europe for 10 years, plus 15 years or so. It is indicated to improve kidney function in adults with hepatorenal syndrome and rapid reduction in renal function. Those with creatinines of above 5 milligrams per deciliter are unlikely to benefit from this drug, so therefore it's not thought to be helpful. Have to mention, of course, adverse events. In the studies, we did see that there were some serious and fatal respiratory failure in some of these patients, patients that were aggressively volume resuscitated, so those with volume overload or with ACLF, the acute and chronic liver grade 3, and we'll talk more about that very shortly, are at increased risk for that. So again, just part of our approach to these patients is understanding what is their ACLF grading based on the CLIF score. And we should be careful about initiating this drug in patients that are experiencing hypoxia until their O2 levels have improved. It is contraindicated in patients, again, obviously with worsening hypoxia, or worsening respiratory status, with ongoing coronary, peripheral, or mesenteric ischemia. This is a vasoactive drug that causes a vasoconstriction. It's been also again, just saying the same thing here again in the second paragraph here, that we should not initiate this drug in hypoxic patients. And if patients do become volume overloaded while they're on treatment, it's important to either reduce or discontinue the albumin that they are also receiving and or other fluids, and be very judicious with the use of diuretics. And we'll get more into that and the safety and so forth. So again, I'm a hepatologist out of Charlotte, North Carolina. I'm not an employee of Mallinckrodt, but I'm paid to be here on behalf of Mallinckrodt. Thank you again for their support for this meeting. This is a very nice meeting that I've been to several years ago. I haven't been in a while. It's a promotional, it's a non-CME. Don't kill me, I have to say all these points. These are the FDA rules. But the slides are consistent with FDA guidelines with the approved labeling for Terlivaz. Mallinckrodt, as a sponsor, has designed this presentation for those who practice medicine and see patients, and they may use this product. And it's not intended to serve as medical advice. I think there is some sort of sign-in sheet that I have to mention this, so just make sure you please follow the rules. And we'll kind of go through the indication, the labeling of this drug. We'll go through some clinical data from the CONFIRM trial. We will try to understand how it may relate with our transplant-related endpoints, and we can go through a patient scenario that may seem quite common in all of your practice. So how do we define HRS? The definition has slightly changed over time, has been refined. So it's considered really functional renal failure with a structurally normal kidney. It's usually rapid in onset. It's seen in a setting of portal hypertension, which ultimately leads to splanchnic vasodilation. There's a reduction in cardiac output, and a lot of this is driven by pro-inflammatory cytokines and chemokines. Again, this usually occurs in a setting of decompensated cirrhosis, but we can see it in some other settings, such as acute alcoholic hepatitis and so forth. And one aspect to understanding this disease is that it can occur in a complex of other organ system involvement, sort of a multi-system organ dysfunction. So by definition, we're already going to have two organ systems involved, the liver and the kidney, and the question is what additional organ systems are involved when evaluating a patient. So this pictorial you can see here, it really starts with cirrhosis. So once we have cirrhosis and portal hypertension, so if I was a hepatologist in Barcelona, part of my practice would be to do my own, I would float a swan in the liver. I mean, I would do direct portal pressure measurements. Some of the cool things that they do as hepatologists in Barcelona. And that's how we define portal hypertension. So there's literally is a high pressure in the portal system or within the liver. This in turn leads to splanchnic arterial vasodilatation as a compensatory mechanism. So what happens, there's effectively a decreased blood volume, arterial blood volume to the kidneys. So the kidneys will see less blood effective volume coming to them. So as a result, there is activation of endogenous vasoconstrictors in the kidney. So which then in turn leads to renal vasoconstriction, which in turn leads to further decrease in GFR. So this sort of really is a system of mechanisms designed to improve flow to the kidneys. And in turn, we then develop what's called HRS, hepatorenal syndrome. So patients with HRS obviously are faced with poor outcomes. As a hepatologist, I feel like I'm also a part-time nephrologist as well too. I've never sat for the nephrology boards, but I think I could give it a good shot. Many of our patients have some degree of renal dysfunction, both in the clinic, inpatient, outpatient setting, and so forth. And why does it make a difference? It makes a massive difference in my world, because once one of my patients now has some sort of renal dysfunction, it changes the whole complete picture for that patient. Without treatment, HRS mean survival is less than 2 weeks on average, and in the hospital with a greater than 80% chance of mortality within 3 months. With treatment, again, this is a bit older data prior to the development of this drug, there is inpatient mortality of approaching 37%, and even 30-day readmission, which we know how much Medicare likes to look at that. A third of these patients have a 30-day readmission rate, and median length of stay is, again, 30 days, many of these patients who are being treated. So what do we have for treatment? Nothing FDA approved until relatively recently. Typically, we've been using either what we call MNO, midodrine octreotide, or norepinephrine. Again, neither one of which are approved for HRS. Norepi, which is usually given in ICU, requires central line monitoring, and so forth, is considered in the guidelines, has been as a second preference now, whereas MNO is considered now a third line preference. The nice part about midodrine octreotide, you can be given on the floor, doesn't require central line, doesn't require cardiac monitoring, and so forth. So the guidelines were recently, from the AASLD, were recently revised just over a year ago. And we have a bit of different criteria and definitions. We used to call HRS, HRS1, and HRS2. Now it's sort of called HRS-AKI. And it's simply when we see somebody with cirrhosis and ascites, and we see an increase in a serum creatinine of greater than 0.3 milligrams per deciliter. So it's a very, very small change. And as we all know, many nephrologists, I'm sure, are here in the room, know that these very small changes can have very, very major impact for these patients. And this is assuming that this has happened within the last 7 days, so it's a sort of an acute rise. Again, this is seen in the absence of shock, and there's no improvement of the renal function despite 48 hours of holding the diuretics and with continued volume expansion with albumin. This is another change I want to bring to your attention because the guidelines for managing renal failure used to indicate that you can give both crystalloid and colloid, so IV fluids, there's normal saline or albumin. The normal saline has now fallen off the recommended guidelines and is now primarily albumin as the volume expansion preferred. And again, no current or recent treatment with nephrotoxic drugs. And I'll go as further to say that there's no other nephrotoxic sort of insults, like a recent CT scan, for example, with contrast that can complicate the picture in these patients. And again, this is seen in the absence of parenchymal kidney disease. So if somebody has known renal dysfunction or medical renal disease, this is, again, seen in the absence of that. So guidance for the treatment has also changed, has also evolved recently. And terlipressin has become the preferred drug in this setting. And where terlipressin is not available, norepinephrine should be given. If neither can be administered, a trial of what we call MNO, midodrine octreotide, again in combination with albumin, should still be administered. And when treating, albumin should be infused at 1 gram per kg on day 1, followed by anywhere from 40 to 50 grams of albumin a day for the duration of therapy. Obviously, renal replacement therapy is as indicated, and so forth. So, again, the major highlight to bring to your attention is that recently most of these societies have changed their guidelines and their preferences where, so the ASLD now has terlipressin as the preferred drug, and the ACG, the American College of Gastroenterology, last year also revised their guidelines as well, with terlipressin now becoming the preferred agent to improve renal function. So I'll take you through a little bit with the CONFIRM trial, and this was the landmark trial that was really the essence of the approval by the FDA just last year. So this was published in the New England Journal. It's the largest HRS trial globally so far. It was, and subjects were randomized in a 2-to-1 fashion, where 2-to-1 treatment arm versus placebo arm, and again, it was a double-blinded study based on a definition of HRS. Now, I will say that the definition here, you can see, is, so this study was done prior to the revision of the recent guidelines. So the study here defined HRS as a creatinine. It was a rapid reduction in renal function to a serum creatinine of greater than 2.25 without renal improvement, despite diuretic withdrawal and an albumin challenge. And after the albumin resuscitation, we did see that there was a mean serum albumin of 3.7 in the terlipressin arm, or the treatment arm, and 4.0 in the placebo arm. And again, I just want to quickly show you, again, this was a 2-to-1 fashion, so we see 200 patients basically in the treatment arm and about 100 patients in the placebo arm. Baseline characteristics were very similar to both groups regarding serum creatinine, MAPS, total bilirubin, mean baseline MELD scores, Child-Pugh scores were similar, and as well as the ACLF grade 3. So again, grade 3 meaning there were 3 major organ systems involved in the acute on chronic liver failure classification. If you look at the percent, you guys can see across the board fairly similar. So 40% of all the patients from this trial were actually transferred from an outside hospital to a study hospital. And again, the mean ages, again, were similar across the board. A very young patient population at 54 years old, extremely young. Most of them being male. Yes, that was a joke. I did hear some laughter. Thank you. Somewhere in the back. Thank you. We're telling our ages now. The majority of patients, their liver disease came from alcohol. And again, the number one indication for transplant for men, we know now is alcohol. For women is NASH. So these are sort of in line with what we're seeing in the real world. Had I given this talk, I don't know, 5, 7, 10 years ago, probably would have been hepatitis C as number one indication, but things have changed quite drastically over the last few years. And there were, as you can see here, a fair number of patients that actually had a diagnosis of alcoholic hepatitis in this trial as well, too. And a fair number of patients did have SIRS syndrome as defined by the criteria. And we can see here that mean serum sodiums were about 133 in both groups. So the primary endpoint as defined by the trial was 2 consecutive serum creatinines of equal to or less than 1.5 milligrams per deciliter at least 2 hours apart by day 14 or by discharge. And also the study looked at survival without renal replacement therapy greater than 10 days. So you can see here in the blue bar, the treatment arm, terlipressin plus albumin, was roughly twice as high as the placebo arm, 30% versus 15% for terli plus albumin. So this is obviously was the primary endpoint. So the study, because the p-value was less than 0.05, was felt to be statistically significant. So this was the main sort of driving force behind the results of the study, which is what led to FDA approval. Looking at secondary endpoints, we did see sustained HRS reversal at both 30 days in the first chart on the left, 14 days, the middle one, both showed superior HRS reversal at these time points. And when we break it down further into complete response and partial response, we do see that there was a much higher with the treatment arm in the complete response versus the partial response, again, as defined here. And when we look at further by creatinine stratification, serum creatinine, when we break it down from 2.25 to 3, to less than 3, and then we break that down from 3 to 5, we do see in both of these groups that there was statistically significant reduction in HRS, there was a higher HRS reversal in both of these groups. When we get to above 5, serum creatinine of above 5 is where we see that the results were not significant. Okay. And again, when we look at rates of incidence of renal replacement therapy, again, through day 14 and day 30, we see again in the treatment arm, there was a lower incidence of renal replacement therapy in both of these groups. When we look at further in a subgroup analysis of patients that went on to liver transplantation, those that were liver transplant recipients, the incidence of HRS reversal again was higher in the terlipressin plus albumin arm, as you guys can see here, almost 3 times as higher. And when we look at RRT incidence pre-liver transplant, again, we see it's lower in the Turley arm versus the placebo arm. And when we see post-transplant, again, there is a lower incidence of renal replacement therapy in the terlipressin plus albumin versus the placebo arm. Getting to adverse events, abdominal pain, nausea, diarrhea seem to be much more common than placebo. And again, no surprise, these are acting on the V1 site and causing vasoconstriction in the splanchnic circulation. Respiratory failure, obviously something to be noted. And again, looking back, we do know that patients that were higher degree of ACLF class had a higher risk of respiratory failure and dyspnea and so forth. Volume overload, pleural effusions, obviously. So keeping this in mind for further discussions about how to monitor patients is important. Bradycardia and ischemic-related events were also noted in higher degrees in the treatment arm. So risk factors for respiratory failure. So hypoxia with a PO2 of less than 90, SPO2 of less than 90%. The guidance says do not initiate treatment until oxygenation levels improve. What happens if somebody becomes hypoxic during treatment? Then the advice is to discontinue the medication. So again, if somebody has ACLF grade 3, and we'll get to that very shortly, it is advisable to avoid the use because of the risk of respiratory failure in these patients. And what if somebody goes from ACLF 2 to 3 while on treatment? Again, it is recommended to discontinue. Intravascular volume overload as assessed clinically, chest radiographs, Swan-Ganz catheters and so forth, really to use with caution and reduce the use or discontinue the use of albumin in these patients as well as other fluids and use diuretics as indicated. And again, what happens if patients become volume overloaded during treatment? Then again, a recommendation is to reduce or stop the use of albumin during that time. So prior to initiation, we should really assess our patients very well to make sure they are appropriate for this drug treatment. Again, making sure we formally make a diagnosis, trying to assess their ACLF grade, knowing baseline oxygenation levels, volume status are all important, and obviously knowing your baseline creatinine. What are we doing during treatment? We're implementing continuous pulse oximetry. We're assessing response at day 4 using serum creatinine and adjusting our dose based on the package label. We are continuously monitoring the patient's volume status. Again, physical exam. I think there's still value in physical exam, although you ask an intern these days, they may tell you what did the chest x-ray show, but we still have a lung exam. And again, if we are sensing that our patients are becoming volume overloaded on treatment, adjusting our terlipressin, albumin, and so forth. And when do we stop treatment? Well, we're reassessing the patients by day 4. If we haven't achieved our response we want to see by day 4, or if there's hypoxia or other adverse events, then we want to stop. If we've achieved serum creatinines of equal to or less than 1.5, at least 2 hours apart, then we can continue on with therapy and complete 14 days of therapy. So that sort of is the guidance about how do we approach these patients before and during treatment, and how do we assess when to stop. So many of these patients during the clinical trials were administered terlipressin while they were on the floor. Again, it doesn't require central line access or anything else like that. Obviously, it requires continuous pulse oximetry, so your hospital needs to be able to provide that on the floor. And there were some patients that were in the ICU, but again, not a majority. And of those that were in the ICU, you guys can see here on the right, that ICU length of stay was shorter in patients that were on the treatment arm versus the non-treatment arm. Obviously, in the liver transplant world, the allocation system has changed, as I was just talking with a colleague a few minutes ago, and how MELD score and so forth. And there's going to be a new change also coming this year, the MELD 3.0. So stay tuned. I think it's going to be sometime the committee has already approved the change. I think coming sometime later this year, next few months or so. Not exactly sure. So patients with a MELD score of 35 or higher, or are considered to be very high priority for transplant, most anywhere in the U.S. So a conversation usually needs to take place between the hepatologists, nephrologists, and surgeons and so forth. And the adverse events may be high enough in these patients where treatment may not be appropriate for these sorts of patients. So the benefits of treating these patients with terlipressin may not be appropriate, and it may be too riskier versus the benefits. Obviously, you need to be aware of the potential for ischemia, because this is a vasoconstricting agent. Cardiac, cerebrovascular, peripheral, and of course mesenteric ischemia have all been described. So being aware of the patient's history and sort of tying it all in together there. And obviously, if somebody develops any sort of ischemia while on treatment, stopping therapy there. Medicine may cause fetal harm, so should not give it to a pregnant patient, although I can't say I've seen many pregnant women with really decompensated cirrhosis in my lifetime. And most common adverse events: abdominal pain, nausea, respiratory failure, diarrhea, and dyspnea. Again, just reviewing those. Let's kind of run through a case for discussion. Certainly, this is something that I think we all may see in our practice, whether we're hepatologists or nephrologists. A woman who is 48 years old, history of cirrhosis and ascites. She's seen in a community hospital, emergency department for ascites and anasarca. She's transferred to an academic medical center for sort of further evaluation, and she's added to the wait list for liver transplantation. As we all know, it doesn't happen that quickly. Prior to presentation, she had ascites that was managed very well on diuretics, spironolactone, and furosemide. Labs from about a month ago show a serum creatinine of 0.8, bili of 8.6, INR 1.2, and a sodium of 132, giving her a MELD score of 17. Of note, her MELD score will change in the new allocation system, because MELD 3.0 should give women, female patients, an extra point or so on the MELD calculation. So her past history is notable for hypertension and hyperlipidemia, no history of any GI bleeding or SBP in this patient. She doesn't smoke or drink. Her home medicines include the usual furosemide, spironolactone, beta blocker, propranolol. Her weight has increased by 10 kilos from about a month ago. Vital sign-wise, she's afebrile. Pulse, her blood pressure is a little on the soft side, 86/50. Pulse is 90, 20 respiratory rate, and her O2 sats are 98% on room air. So in general, she's sort of a sickly appearing patient. She's jaundiced. Nothing exceptional on the cardiovascular or the pulmonary exam. Her abdomen, she has a moderate ascites with an umbilical hernia, a very common scenario I see in my practice. She's got edema in her lower extremities, and she was reporting a decreased urine output with normal bowel movements. So lab-wise, you can see here her white count is normal at 7.2, normally low platelets for a cirrhotic patient, 86. AST and ALT, as you can see here, mildly abnormal, 67 AST, 35 ALT. Hemoglobin is okay at 9.2 rather. Her serum creatinine is now 2.6. Her bili has jumped up to 21. INR is 1.7. Serum sodium is 132. Her K is okay, and her MELD score is now 33. Her chest X-ray shows no evidence of volume overload, no vascular congestion, and so forth. She got a diagnostic paracentesis that shows no evidence of SBP. UA was normal, no proteinuria, no hematuria or UTI, no infection. Blood cultures were obtained, still pending. Her EF was normal. RVSP, as you can see here, was 38. Her ultrasound showed a cirrhotic appearing liver, ascites. Her portal vein was patent, incredibly important to make sure we know the portal vein status, especially for our surgeons in the room. You're welcome. And a renal ultrasound showed normal appearing kidneys, so no evidence of chronic kidney disease in this patient. So based on the newly revised ASLD guidelines, what are some initial treatment? What is the number one most important thing for this patient? Is it to give her empiric antibiotics? Is it to give her albumin plasma volume expansion? Should we give her MNO to treat her HRS-AKI by the new definitions? Or should we increase the dose of her beta blocker? I won't look, but you guys can mutter under your breath what you guys think might be the answer. And so the new guidelines would say that we should expand her volume with albumin as now the preferred agent. Again, it used to be crystalloid, but no longer are those in the guidelines. So, of course, we stopped her diuretics. We stopped her beta blockers. We didn't want to further drop her blood pressure. We gave her albumin at a dose of 1 gram per kg per day to expand her volume. And after 2 days, her creatinine went from 2.8 to 2.9, so she's not getting better. So she's meeting the criteria now for HRS-AKI, again, based on previous baseline serum creatinines. So thinking about this patient, what can we now offer her? Or what would be in the guidelines? The guidelines would say to offer her terlipressin as treatment for AKI-HRS. And again, we have to, so as we're thinking about this lady, we want to make sure we go through our checklist to make sure that she really does not meet any contraindications such as hypoxia, ACLF grade 3, volume overload, and so forth. And so this is the criteria based on the CLIF-SOFA scoring system for ACLF. And we can see here we're assessing obviously the liver, the kidneys, their coagulation system, their cerebellar function with hepatic encephalopathy, and their pulmonary status as well as their circulatory status. So kidney-wise, what is their creatinine? And you guys can see here the cutoffs for on the scoring system. What is the bilirubin to assess the liver function? What is the INR to assess the coagulation function? And what is her grade of encephalopathy? And what is her pulmonary status, as we can see here, based on FiO2 and PO2 and so forth? And is she on pressors or not? So I want to say very important for this patient, she meets criteria for ACLF grade 2, so she would be deemed an appropriate candidate to receive HRS therapy with terlipressin. So on day 3 of hospitalization, she's given terlipressin, 1 vial a day, every 6 hours rather, plus the albumin is continued at 30 grams per day. Of course, during this time, we're doing continuous pulse oximetry monitoring. On day 6 or day 4 of treatment, she's reassessed, and her creatinine is back down to 1.8, so it seems to be responding, and her serum sodium is normalized to 136. Terlipressin is continued at the current dose. Her MELT score is 30. Her O2 levels remain stable. So 14 days of treatment. Her serum creatinine remains at 1.7. That we can see here, she has not required renal replacement therapy because her creatinine is not getting worse. And 25 days after she's admitted, she is transplanted with a deceased donor liver transplant. Renal function is stabilized, and post-op she's given calcineurin-based immunosuppression therapy. And again, she did not require RRT post-transplant, which is always nice. And she sent home 9 days post-transplant. So I think the key here to really emphasize is that we have to make sure we diagnose this condition early, because the earlier we treat it, the more likely the patients are to respond to treatment. And again, that's what we see in the most recent updated guidelines from the AASLD. And again, once we make this diagnosis, to consider the appropriate treatment, terlipressin, if available, at your medical center. We know that patients that received terlipressin were dialyzed or received renal replacement therapy to lesser degrees, both before and after transplant. Again, I want to review that most common adverse events were abdominal pain, nausea, respiratory failure, and dyspnea. And again, making sure that we choose our patients appropriately, staying away from ACLF grade 3 patients with volume overload, hypoxic, and so forth. And again, if there's a creatinine above 5, there likely would not be any benefit to giving this drug. Thank you for your attention this morning. This is sort of, I'll leave this up here for your perusal after I'm done speaking. I'm happy to take any questions now. Thank you to AST for the support, and thank you to Mallinckrodt for inviting me here to speak. Thank you.
Great presentation. Good morning.
Morning.
I'm an abdominal transplant surgeon from the Chicago area. Used to deliver transplants in a past life. Moved to kidneys. We also do hard kidney transplants, and you often see cardiorenal syndrome. Now, this obviously is off-label, and you can choose not to answer the question now.
I'm sorry. Say it again. What you see often? I didn't hear that part.
Cardiorenal syndrome.
Yes. Yes.
So.
The nephrologists love to play tug of war with the cardiologist.
Yeah.
They push, you pull.
Exactly. They want to dry the patient and keep them wet. Yeah. But any thoughts of using this, pre-transplant in these patients who have, say, a BIVAD, the ventricular assist device, and now they may need dialysis. They wait on the wait list for a cardiac transplant with a kidney transplant, maybe. So any thoughts of using it in that setting? Yeah.
Well, thank you for the question, first off. Thank you. I guess you're a recovering liver transplant surgeon.
Yes.
Recovery.
Yes, very much so, yes.
Thank you. Well, first off, it's got to say up front, this is not indicated for that particular condition, number one. I think with that physiology, that's part A. Part B, I think what may be driving the physiology of these patients may be a little bit different than the classic HRS patients where we're seeing the revving up of their renin-angiotensin system. That's primarily being driven by the splanchnic vasodilatation. I don't think we're seeing the same degree of splanchnic vasodilatation with these these heart liver, with these heart kidney patients. So I don't think we're seeing the same splanchnic vasodilatation. But I'm not aware of any data using terlipressin in those patients, and I'm not sure if the company has any comments on whether they're going to study that or not, but I'm not aware of that data.
I just had a sidebar conversation with Dr. Pinney, who's a cardiac transplant guru. He said, forget about it.
All right, well, very good.
think he was paraphrasing. So yeah, Sean Penny from University of Chicago. I think in cardiorenal syndrome, there are two things that are active. One is a low cardiac output,
Right.
and the second is renal venous congestion from high central venous pressure. So the mechanism, as I understand with terlipressin, is splanchnic vasoconstriction, increasing venous return to the heart. And I'm assuming that's also one of the reasons why you see respiratory hypoxia. So probably not the best mechanism in patients with cardiorenal syndrome.
Right.
Are there any other mechanisms as to why this might cause respiratory failure other than just shunting of blood from the splanchnic circulation to the central circulation?
Well, I think some of the theories that have emerged were that, and I think we're still trying to refine our understanding of how do we use albumin. So many of these patients may have been volume overloaded, and that was a big discussion, with trying to analyze this data, because the albumin was not standardized across the board for many of these patients. So there were varying degrees, but there seems to be a thought that albumin led to that. I suspect that Josh Levitsky may have some further thoughts on that, since he was one of the investigators as well, too, and a leading thought person in this area. But I think it's sort of a volume overload, and where do patients fit in this? Did we push them to go from ACLF grade 2 to grade 3? That I suspect that what may have been the cause for all this, as our understanding of ACLF has become more sophisticated over the years. So, Josh, I'd like to hear what you have to say.
I was just going to comment on this cardiorenal syndrome, because there's growing evidence in the liver population that they develop something like this, but it's a different physiology, meaning they have very high cardiac output, often sometimes sort of right heart failure, and they get massive anasarca and edema, and they can get kidney congestion too, sort of a similar physiology, but it's high cardiac output, low systemic vasodilation, low blood pressure. But actually in that circumstance, when you see that, I think without like a lot of ascites, but a lot of just peripheral edema, kind of just congested kidney, the better treatment is to actually diurese them.
Yes.
Aggressively, and actually you'll sometimes see them. So that really isn't. It's a similar physiology in a way to the kidney seeing the same thing, right? Renal vasoconstriction.
Right.
But actually diuresing them and getting some forward flow and decreasing the congestion in the kidney will actually improve the creatinine. You don't see this a lot, but we do see this sometimes, and it's usually almost kind of like right heart, biventricular sort of failure, even though the heart is really pumping strong. So I think you have to look at the clinical circumstance of it. Typically, when I see HRS, it's large amount of ascites, hyponatremia, hypotension, maybe some edema, but when you see the situation of these cirrhotic patients with massive edema and anasarca, not a lot of ascites, oftentimes it's high output cardiac failure, and then diuresing them, and then you have to optimize them going into a transplant, because you don't want to go into a transplant in that situation.
Right.
So I think there is this kind of type of cardiorenal syndrome, which is different from what you guys see. Yeah.
And I think it makes us very nervous when we see the nephrologist come along and give them a big slug of furosemide IV, but then they get better, like you said. So, yeah, absolutely.
Yeah, hi. I'm another cardiologist, so let me throw in 2 cents here. What we're seeing actually now is congenital heart disease, and these patients are coming now into adulthood, so they are surviving univentricles. And these patients have biventricular failure. We're seeing Fontans,
Yes.
Fontan-associated liver disease, which is quite prominent, actually. And so we're now seeing liver failure with heart failure, congestive hepatopathy that ends up with cirrhosis. And so we are seeing things like this. It's a combination, actually, of both hepatorenal syndrome and cardiac renal syndrome, cardiorenal syndrome as well. So there may be a role in something like this for some of our severe patients. So,
Right.
so I don't know if I would actually, turn a blind eye to this, it might be something that may be of value for us in those situations where we see this FALD.
No, I agree, and I'm, as a hepatologist, seeing more and more of those patients. You're right, because they're growing up and becoming adults now, so they all have some degree of liver disease and get hepatocellular carcinoma and so forth, so you're right. I mean, that I'm aware of, I don't believe there were any patients there were Fontaine patients in any of the clinical trials. They probably would have excluded those patients, I'm sure. Certainly having an abnormal echocardiogram would have made that exclusionary criteria. But you raise a good question, because many of these patients have more than one thing going on. That's the real world we live in. Thank you. Well, thank you for the good questions and good discussions. Thank you again to Mallinckrodt for supporting this program. Have a good day.